Dr. Samadi, without any particular warning signs or symptoms for men to look for, what is prostate cancer, or how is prostate cancer diagnosed if there isn't a specific element to look for from the patient?
Basically, we're talking about prostate cancer screening, which involves getting the annual test, which is called a PSA, prostate-specific antigen, and that starts by the age of 45. You get a baseline. If there's a family history, then you have to go through annual blood test, and also the prostate exam, which you will do at the same time. So screening involves the blood test and the prostate exam, and you would start doing that at the age of 45 and onward. It's very easy, simple test, but what's important is also not the actual value of the PSA. That's important, but you want to make sure that you look at the trend of this test. You want to look at the velocity of it and realize what it was a year before and a few years back and see if there's a big jump. And that's really the red flag that you have to be aware of.
The other thing we have is we have oftentimes the PSA is elevated, and there are other reasons, and we have a slide for it that Dr. Samadi can discuss.
So as you can see over here, there are many reasons why the PSA could be elevated. You've got to make sure that before you do the test, there should be no sexual activity for 24 to 48 hours that can jump in the PSA. Enlarged prostate is another reason. If you have a 20-gram prostate versus 80-gram prostate, the PSA secretion would be totally different. Infection can cause this. Any kind of infection or inflammation called prostatitis can elevate the PSA. And, you know, obesity and other things can play a big role. Now, over here, we have certain medications, and the big one here is saw palmetto. That's a herbal medication that a lot of people may or may not know. But if you are on saw palmetto, that reduces your PSA by half. So if the doctor, for example, give you the PSA of 2 and you're on saw palmetto, you have to double that. Your actual number is 4, and that's a very important. Whether activities such as biking or riding a horse can increase the PSA, we're not 100% sure, but any kind of activity around the perineum where the prostate sits can potentially increase your PSA level, and you want to be very cautious about that.
The screening test is rather a very simple process. So in your experience, why are men generally so resistant to be properly screened?
You know, I think men are very different than women. Women, they always get the mammogram once a year, and that's almost written in their annual checkup. For men, this is a little bit of maybe like the macho factor, maybe it's the masculinity. We're afraid of going to the doctor, bottom line. And part of the prostate exam, there's some taboo with that. But the truth is that with a simple PSA test and a simple prostate exam, you can save lives. And I see these really young men in their early 40s, 50s that are diagnosed with lethal prostate cancer, and that could save their life. So it's really up to their partners and the wife and spouses to bring them and say, look, you got to check your PSA and know where you stand.
Let's discuss a patient who comes to you for the proper screening and has a positive result. What happens then?
Well, at that time, there's a big discussion going on. We have to look at, it's a detective work. You have to look at the entire picture. You have to look at the entire patient, see what kind of medical issues they have, what kind of history, family history they have. But typically, younger patients in their 40s, 50s, early 60s, they choose to go for removal of the prostate.
We have the Gantt chart here that explains the options.
Exactly. So these are all the options that are available. Typically, what I tell the patient is that if you have cancer, you want to get rid of it. Removal of the prostate is probably the best option for younger men in their 50s and 60s. Why? Because you will know how much cancer you have. The cancer is removed. You will know what's in the seminal vesicles, your lymph nodes. PSA after surgery has to be 0. So we have a marker that we can follow. If surgery fails and the cancer returns, then you can use radiation afterwards. So I think the tide is changing. Years ago, we were talking about seed implant and radiation. Now surgery is more popular, especially these robotic prostate surgeries that we do.
You know, the other flip side of what Dr. Samadi just said is very important too. Radiation failure and then going back and do surgery is very, very difficult. All surgeons know that. To operate on a radiated field is a very difficult operation. It's encased in cement. So you don't have the same kind of option. If surgery failed, you can do radiation. Vice versa is very difficult.
And talking about that knowledge, Dr. Lazzaro, when you were diagnosed with prostate cancer, as a surgeon, obviously you have a bevy of medical information at your disposal that most people don't have access to. So walk us through the process of how you decided on your treatment plan, and what treatment plan did you ultimately choose for your own health?
Well, first of all, I'm a surgeon, so I'm wired that way. When there's a problem, I like to get rid of it. The first thing I thought about when I heard that I had prostate cancer is I want to have it out. Now, if you are medically fit, and it's what we talked about in the past, keeping yourself in good shape keeps you ready for something like this that could be life-saving. If you're not medically fit and you're not a good medical or surgical candidate, you can't have surgery. You have to have other modalities. And I happen to think once you have this out, that's the best modality. So for me, surgery was the way to go. Now, the selecting a surgeon, that was a whole nother thing. There's open, as we saw, there's laparoscopic, and there's robotic types of surgery, and there's different types of physicians that do each one of them. Dr. Samadi is unique in that he has done all three of them. So this is, he can do the surgery, he's done each one of them, and what happens if, listen, a robot is a technical piece of equipment that helps you function. If that breaks, what happens? Well, the person who's using it can do the other types of operations, which he knows how to do. So to me, it gave me three surgeons in one, and it gave me the comfort level. The robot is the way I want it to go because it can magnify everything. You get better view. Dr. Samadi will show us and elaborate on this a lot more. And that's how I decided on him. And one of the most important reasons I decided on him, after I found the 5 surgeons in the United States that did the most volume, which he was one, I narrowed it down to 2. I called the other institution and I asked them if they did the whole procedure. I'm a surgeon. I know that there's residents, there's interns, there's fellows. Who's doing the operation? At the other institution, they told me that the doctor does, the main fellow I was going to, does the important parts. And I asked him which parts weren't important. When I talked to Dr. Samadi, he does all of the operation from beginning to end, and that's what sold it for me. As
a patient, every part of that surgery is the important part. When we continue more with Dr. Lazzaro and Dr. Samadi, including conversation about the cutting-edge technology of robotic surgery right after this. Don't go away. And welcome back to Aesthetic Medicine. Now a privileged journey into exactly what robotic surgery is.
This is a natural process for us because as a surgeon, I started with open surgery and then moved on to laparoscopic surgery, and now we're doing it in a remote control. These are the two handles that we use. So this is the right arm, that's the left arm. And then here, these are all the pedals. So I move the camera anywhere in the abdomen. This is the clutch where I can switch arms, and these two are the monopolar. And of course, you know, it's basically what you see here is exactly what's going on inside the patient's abdomen. So the robot doesn't do anything autonomously. Full control is under the surgeon's maneuvers. All the movement of the robot is done by surgeon completely. So instead of having the patient open, the robot is basically the extension of my arms inside the patient abdomen. Using the camera, I'm able to maneuver around the abdomen through the cables. The movement of the surgeons are translated to the tip of the instruments. Having this CO2 gas, it allows us to work in a bloodless field. Even though the distance is about 8 to 10 feet away, it's under a very controlled setting. Not only the visualization is better, it's a much more precise way of doing the operation.